Asthma attack. Does anybody have any firsthand, secondhand experience with asthma? Okay. Yeah. All right, Jaden Hunter, 11 years old, stumbled into his parents' bedroom. It was 4 a.m. and completely dark. He was unable to talk, and he grabbed his mother's foot to get her attention. Without explanation, she knew what the problem was. So she went downstairs, got the backpack, and she slipped a mask over his face, which delivered nebulized albuterol. Okay. So she was recounting the events of the day, and Jaden was on a field trip to a local racetrack, and one of the drivers gave him warning, but said, I'm going to rev up the engine and whatnot. So he revved the engine, and it followed by a plume of green smoke, which is nitromethane exhaust. And Jaden immediately needed his quick relief rescue inhaler. And then his mother took him home. Okay. Let's see. Question number 1. According to the passage above, what are 3 factors involved in the airways that lead to an asthma attack? So Jaden's having an asthma attack here. What's going on with his lungs? What are 3 factors that are happening in the lungs that are causing an asthma attack? Yes, David.
Chronic inflammation.
1, chronic just 1 is good. Chronic inflammation. Increased mucus production. Good. And I'll say that chronic inflammation leads to swelling of the lungs. So chronic inflammation, swelling of the lungs, and then increased mucus production. And anybody else for the third?
So the swelling, not count as one of them?
I would count inflammation leads to swelling. Oh. So I would count those at the same. The third one is down towards the bottom. Bronchoconstriction, good. Constriction of the smooth muscles around the bronchioles. Okay. And just to, at what level of the respiratory tree is bronchoconstriction occurring at? Is it occurring in the trachea? Is it occurring in the large primary bronchi or even the lobar bronchi? Where is it occurring mostly? In what we call the bronchioles. The bronchioles are microscopic. They're, well, maybe not. They're, millimeters or less. And remember, the bronchioles don't have cartilage around them, but they have a full layer of smooth muscle that wraps around those bronchioles. And it's the bronchioles that directly feed the alveoli. Okay. What is contained within a quick relief rescue inhaler? Albuterol. Well, I think the all refers to a steroid. And what does albuterol do to help with the asthma attack? It expands the airway, but how does it do that? It relaxes the muscle. So it's a bronchodilator. Good. Let's see. I'll go ahead and read this. So asthma is a condition caused by chronic inflammation of the small airways in the lungs, the bronchioles. This leads to swelling and increased mucus production within conducting zone passageways. Due to the chronic inflammation, in asthmatics' airways are already more narrow than the airways with the individual without this disease. Then it gives you some conditions that can stimulate an asthma attack. So, for example, exposure to dry air, contact with pollen. This usually doesn't cause a problem with a non-asthmatic, but for someone with asthma, bronchoconstriction can severely decrease the diameter of the already swollen mucus-producing airways, making it very difficult to move air into and out of the lungs, and this decrease in airflow can be life-threatening. Okay. What is nebulized? albuterol. Did he get hooked up to nebulized albuterol at some point, or is that just what's in the? Oh yeah, okay. So that was on the mask that she had at home. Okay. What is nebulized albuterol? Turns it into a fine mist. Good. I assume albuterol is in the
I Googled it and it was like albuterol or levobuterol, and they're kind of this. It's similar to Speedstip, and all of them are pretty much excavations. They can kind of help treat it, but I didn't really get to see what it does. But I'm assuming it's like bronchodilator.
So let's think about this. You're having an asthma attack. Your airways are already inflamed. You already have increased mucus production, but that cold air, that pollen, that smoke from that plume from the thing, that's causing bronchoconstriction, and that's what's putting you over the edge. And so in the albuterol and the quick relief inhaler and on the mask, that's going to be something that leads to bronchodilation, right? To get it back to that normal state. And later on in the case study, the doctor talks to him about long-term medications that decrease the inflammation, that decrease the mucus production.
That's that last thing out of errors.
I think so, yeah.
So what would we write pushing for? Do we just say a vapor that helps bronchodilate?
Yeah.
What delivers the albuterol in this? Quick relief rescue inhaler. I think that still has albuterol in it. The mask I think has the nebulized albuterol.
Let me read the answer key here. It says nebula. So question number 2, most quick relief inhalers contain a medication called albuterol, which is a bronchodilator. Question 4, nebulized albuterol is a liquid albuterol. It's broken up into fine mist by a machine. The fine mist is delivered to the lungs through an oxygen mask for an extended period of time, usually several minutes. While quick relief rescue inhalers are small enough to fit in a pocket and are portable, a nebulizer is larger and generally requires a power source. So those quick relief inhalers aren't necessarily nebulizing it. They're not doing it into that super fine mist that you need to get all that better delivery.
They're just getting some albuterol in it.
Yeah, exactly. And it's in a mist, I guess, but it's not a fine mist. Part 2, following his nebulizer treatment, Jaden was breathing a little bit better and able to talk. But the next day, he's like, we used my nebulizer right before bed, but I still couldn't sleep. My chest feels tight. And so they realized that the symptoms had reached a point where they couldn't be adequately managed at home. And so they go to the hospital. And as they arrived at the hospital, Jaden's chest tightness was once again beginning to increase, and he was unable to talk or take deep breaths. This panic led him to tears, which made his breathing problems worse. And his mom stayed calm and helped him with the breathing exercises that would help it. So once back in the examining room, a pulse oximeter was immediately placed on Jaden's fingers and vital signs monitored. Jaden's oxygen saturation was 82%, and that's the percentage of his hemoglobin binding sites that are bound to oxygen. Based on his oxygen saturation as SO2, what's the partial pressure of oxygen dissolved in Jaden's plasma? Well, let's look at this graph. Here we have the partial pressure of oxygen on the x-axis, and we have oxygen saturation of hemoglobin on the y-axis. And so this is the value we know. We know is oxygen saturation, that's 82%. So if we go, there's about 82%, and we follow that across, and then follow that down. What does that give us for the partial pressure of oxygen in Jaden's blood? About 50 millimeters of mercury. Did everybody see how we got that? It may be 48. Yes, it may be 48. Anywhere in that range is good. We want it to be more accurate. We could be more accurate there. What's the normal expected oxygen saturation for arterial blood?
40.
That is the no. You know what? This goes back and it relates to those values. I was like, do these correspond to the values we were talking about the other day where it showed the partial pressure? So after blood goes to the lungs, it becomes oxygenated, and then it goes to the left side of the heart and goes into systemic circulation. Does anybody remember what that value for oxygen was on the chart? It was 95 millimeters of mercury. And according to the key here, the normal expected values are anywhere from 80 to 100 millimeters of mercury. So he is well below that. Why is this happening? Why is his partial pressure of oxygen low? What is it that's happening with the asthma attack that is that's causing that oxygen level to go down? Yeah, pulmonary ventilation is the movement of air into and out of the lungs. What's happening to the movement of air into and out of the lungs during this asthma attack? It's going down. So if you're taking less air into the lungs, what's that going to mean for the amount of oxygen that's moving from the lungs into the blood? It's going down. Exactly. So you could say something like decreased ventilation leads to decreased oxygen in the blood. Yeah.
What is the arrow that's pointing up 40?
I don't know why that's there.
I think it's supposed to say that like when it's in the blood, the lowest is 40 millimeters of mercury, and when your lungs get to 100% oxygen, it'll move. That's why it's got that arrow on the side. That's the volume of the oxygen that'll be unloaded into the tissues.
You know what? Yeah, there's 40 millimeters of mercury, and you're on the right track. Sorry to interrupt you there,
No,
but you're at here's the capillaries, here's the cells, and we say this is 95 millimeters of mercury of oxygen. What was the pressure in the tissues here? 40. It was 40. So that might be what it's referring to, is the pressure in the tissues is 40 millimeters of mercury. Yeah, that's it. Maybe we'll address it here. Okay. Part 3, because asthma is an obstructive respiratory disease caused by a decreased diameter in the respiratory passageways, Jaden was having problems both breathing in, breathing out. Airflow through the respiratory passageway, and this applies for blood flow through the blood vessels as well, can be calculated using the following formula, where F, or airflow, and again, can also refer to blood flow, is proportional to the pressure difference over the resistance. If we're just breathing normally here and we're at sea level, what's the pressure, atmospheric pressure at sea level? 760. And what if we breathe normally and our lungs expand just normally during eupnea? What's the pressure inside the lungs? 757. So the delta P is 3 millimeters of mercury. And what this is saying is that if you increase that pressure difference, either you increase the air pressure, which you could do if you went underground or something like that, or if you decrease the pressure in the lungs by expanding your lungs more, if you lower that, that's going to increase the delta P, and that's going to increase airflow. The bigger the pressure difference, the more airflow you're going to have. Question 1, how does the body create a difference between atmospheric and intrapulmonary pressures to cause airflow to and from the lungs?
The respiratory muscles contract, it's the line with the thoracic cage and the lungs within the change. The lung volume changes, so this gas pressure changes.
Exactly. So how does the body create a difference between atmospheric and intrapulmonary pressures? It changes volume of the lungs. And when you change the volume of the lungs, you change the pressure in the lungs. In Jaden's case, which factor in the above equation changed, causing airflow to decrease? Was it delta P, or was it resistance? The answer is resistance. I could argue that it's both. But basically, let's say you have a tube that's this diameter and you have air or fluid going through it. Where's the resistance coming from? If you have air going through this tube, like through the respiratory tubes, where's the resistance coming from? It's coming from the walls of the tube. Okay, the air rubs against the walls and that creates friction, that creates resistance. So what happens in an asthmatic is that these become constricted. What does that do to the resistance if you have a smaller space in there? Less volume goes through, but basically there's more surface per volume. You're increasing resistance because there's more, the ratio of surface area of the walls to the amount of air that's going through goes up. You have more resistance. If you have a big tube like this, a lot of air can pass through with little resistance. But if you have a tube like this, only a small amount of air can pass and it encounters a lot of resistance. On that same note, if you decrease the volume by bronchoconstriction, that's also decreasing the volume, which increases the pressure, which decreases the delta P. It also makes it harder to go in and out. The answer that they're looking for is the resistance. Okay, when you bronchoconstrict, you're increasing resistance. But I could make an argument, and I think that's where you were going, Adam, that it could also decrease the pressure as well, decrease the pressure difference. Can we just move on from that one? Okay. Without medication or treatment, how could Jaden compensate to maintain airflow? So his pulmonary ventilation went down. His amount of air that's going into and out of the lungs went down because of this bronchoconstriction. What could Jaden personally do to increase that pulmonary ventilation?
Or take deeper breaths.
Increase respiratory rate. And I'm sure as part of those breathing exercises, he's also increasing respiratory depth. So intentionally increasing the depth of breathing.
That's increasing delta P.
It's increasing flow because it's increasing delta P. When you expand your lungs forcefully, that increases volume, which really drops the pressure. And so that increases the delta P. That's the mechanism behind it, yes. So is the pulmonary ventilation is going down. What do you think that's going to do to his levels of CO2 if we're not inhaling or exhaling as much? What's going to happen to CO2? It's going to go up. Okay. And why is that a problem if your CO2 levels go up in the body? Causes the blood to become acidic. And then we get into this part of respiratory physiology, which honestly I'm not too savvy on. Has to do with something called the Bohr effect. But the question is, how would Jaden's increase CO2 levels affect the rate at which oxygen is dissociating from hemoglobin? And keep in mind that CO2 competes with oxygen for binding sites on hemoglobin. So if you have an elevated level of CO2, what's that going to mean for the amount of oxygen that's dissociating from the hemoglobin? Is oxygen going to dissociate more or less? More. Okay. So it's going to increase the rate at which oxygen is dissociating from hemoglobin, which isn't necessarily a good thing, right? Because we want it to dissociate at the tissues, but if it's just doing this in the blood, then your oxygen carrying capacity has essentially gone down.
I have a question. Question 4 and 3, I'm kind of confused about them because it seems like for question 3, from my understanding, you would increase respiratory rate, increase respiratory depth. But
right, that was supposed to be up there on question 3.
Okay. But then for question 4, would you also write the same thing because that would put more pressure on the body because the muscles would be contracting more and that would be using up more energy?
So the question here is, why can all this be exhausting for the sufferer? And that's exactly right, because it requires respiratory muscles to increase that respiratory rate, increase that respiratory depth, and muscles tire out. Okay, part 4, spirometry. We had some physiology equipment. We could actually do this in the lab, but spirometry is a test that's as part of a normal routine checkup for an asthmatic. During the test, the patient is required to breathe through a tube that measures airflow into and out of the lungs. Provide definitions for the following: tidal volume. So let's look at this here, and on the y-axis we have volume. That's the volume of air moving either into or out of the lungs. And tidal volume is represented by this movement right there. What would, how would you define tidal volume? It's the amount of air inhaled or exhaled during normal breathing. What do we call normal breathing? Quiet breathing or eupnea. Quiet breathing or eupnea. What about inspiratory reserve volume? It's the amount of air that you can inhale after a normal inhalation. So if you pretend that you do a normal quiet inhalation, and then anything extra that you can do on top of that is the inspiratory reserve volume. Just got lightheaded. So we'll say amount of air inhaled after normal inhalation. And on that note, what would expiratory reserve volume be? It'd be the amount of air exhaled after normal exhalation. The amount of air that can be exhaled. What do you think's happening to each of these lung volumes with an asthma attack? They're all going down. All going down. Let's see, explain why spirometry can be used to get an idea of basic lung function in suffering from an asthma attack or not. Well, I mean, we just talked about that. We know what normal lung volumes are. Normal lung volumes are known. And so any aberration from that would indicate obstruction to airflow. So lower lung volumes or lower values would indicate obstruction or decreased airflow. Sound reasonable?
What about if it's higher? Would that also have to be something with a respiratory disorder?
If it's higher, and maybe that'd be, I don't know what could make your lungs go higher unless, because you do the max you can inhale, what would cause that to get higher? How could you increase that even more? Your lungs turn to.
If you were born with like a larger set of lungs, which allowed you to get more air into you.
But that's still your normal, that's still that individual's normal inspiratory reserve volume.
But would it differentiate from like the average human's normal?
Yeah, sure. Yeah, you can compare these values between individuals for sure. Jaden's asthma specialist, Dr. Palmer, was on call to see how Jaden was doing. Jaden had been placed on a continuous nebulizer and 20 milligrams of prednisone. And let's see, looks like we've had some improvement. Blood oxygen levels have been above 90% for a while now. If he can keep it above 90%, he'll be able to go home. And yeah, so let's answer the questions. Using the oxygen hemoglobin dissociation curve to determine what Jaden's pressure of oxygen is if his oxygen saturation is 95%. So he's doing better now. His oxygen saturation is up to 95%. And what does that mean for his pressure of oxygen in the blood? Let's see, this is 90 right there. So I split the difference, said that's 95 right there. So if we move across, then move down, say about 80.
What about if you got 70?
70 and 80 are really close.
Okay, so let's see, maybe it really crosses right there. Okay. All right. Okay. So is PO2 is 70. millimeters of mercury. You know, what's interesting about that is that, you know, once you get up into these higher levels, slight increases in oxygen saturation lead to large increases in partial pressure change. Yeah, okay. Maybe. Why is Dr. Palmer's concerned that Jaden's oxygen saturation stay above 90%? What does it mean if it's below 90%? It's not getting enough oxygen, and below 90% is what is considered hypoxia. Hypoxia is just low oxygen levels. Let's go to question 4 here, because he continued to be on the nebulizer, but they also put him on prednisone. Prednisone is a synthetic medication, but what is prednisone basically mimicking? It's a steroid. What specific steroid is it mimicking? Cortisol. Cortisol. Remember, cortisol is produced by the adrenal cortex during the long-term stress response, increases blood sugar, but it's also a powerful anti-inflammatory. Okay. And then the doctor inquired about the long-term asthma medication, this Adavir, and what is the Adavir doing? What symptoms is the Adavir attacking or trying to reduce for this long-term response? I don't know if it's so much the smooth muscle that it's acting on.
Actually, I looked it up. That's 2 things. It does act on the smooth muscle.
Okay, there we go. So it relaxes, we'll say it bronchodilates. What I had down is that it decreases inflammation, and it also decreases mucus production. If you decrease inflammation, you decrease mucus production, then even if you do have something that constricts the smooth muscle, you don't have those compounding factors that are going on. Cool. Respiratory physiology can be complicated once you get into details and you do these dissociation curves and all that type of stuff. All right, so for next week, we're going on to the urinary system. On Tuesday, I'll do a urinary review. I'm going to review all the urinary system on Tuesday. So please watch the material prior. Then we'll go into the lab and do our lab stuff. On Thursday, I'm going to talk about acid-base balance, because acid-base balance involves the respiratory system and the urinary system. Then we're going to do a case study related to acid-base balance in the urinary system. And then that will be it. Yes?
When would you post the case study?
Is it not?
I'm not sure. I've never checked, but I might not be